that these are four chambers in the heart: the right atrium, the right ventricle, the left atrium, the left ventricle. The heart works by electricity, كهربائية. Okay. There is a generator which is called the sinoatrial node. This is the sinoatrial node. It's present at its location in the upper part of the right atrium. Then from there, a bundle comes down. This bundle is called to the atrioventricular node. This is the atrioventricular node. And a small branch will go to the left atrium to activate the left atrium. This is Bachmann's bundle. Okay, so the SA node gives an impulse which goes down to the AV node, and then from the AV node to the bundle of His. This is the bundle of His. The bundle of His, lower down, it goes from the atria to the ventricle. In the ventricle, the bundle of His divided into two branches, left and right. And each one of them is divided into left anterior, left posterior, and then it will form the Purkinje fibers. Okay, this is the anatomy, which is very important. Show me next slide, please. Yes. This is the refer to the automaticity. And I wish to tell you what is automaticity, because this is very important term. Okay, if you the heart normally is under sympathetic and parasympathetic. The sympathetic causes acceleration of the heart rate, and the parasympathetic causes deceleration of the heart rate. If you denervate the heart, i.e., you remove all the sympathetics and all the parasympathetics, the heart will not stop. The heart will work automatically, and this is called automaticity. A normal heart automaticity is 100 beats per minute. And this occurs in conditions like diabetic neuropathy. In diabetic neuropathy, the sympathetic and the parasympathetic, both of them may get damaged. And if they get damaged, then the heart will beat at a constant rate of 100 beats or near 100 beats per minute. If the patient exercises, it's 100 beats per minute. If he goes to sleep, it's 100 beats per minute. This is the automaticity. Next slide, please. This will show you the innervation of the heart. You can see that there is a sympathetic plexus coming to the heart, and there is a parasympathetic plexus coming to the heart. The parasympathetic from the vagus nerve, both vagi, the right and the left. Next slide, please. Yes, this is a very important slide which you have to, I'm sure you all know this. Okay, this is the normal cardiac cycle on the ECG. Okay, this is the P wave, this is the PR interval, this is the QRS complex, and this is the P wave. Okay, normally what happens is this: the atria contract while the ventricles are dilated, and this is atrial contraction. On the ECG, this is corresponding to the PR interval, and this takes normally 0.2 second. Then ventricular contraction will start. And the ventricular contraction is shown on the ECG by the QRS complex. And you all know this is about 0.11. Okay? Then the ventricles will relax ready to get refilled. This is called ventricular refilling time. This is the T wave. Okay? Okay, you have to know this very well. This is the QT interval, the QT from the beginning to the Q to the end of the T. This is called the QT interval. This is the PR interval. This is the P wave. This is the QRS. Next slide, please. Atrial dysrhythmias, we are going to discuss today, inshallah. Ventricular dysrhythmias will be part 2. Okay? Causes of atrial or underlying mechanism, first of all, automaticity. If the automaticity goes very fast or very slow, this is number 1. Number 2, trigger activity. And number 3, re-entry. And I will discuss this probably in a later lecture. What does re-entry mean? You will understand what's re-entry when you study the Wolff-Parkinson-White syndrome. Next slide, please. As I said earlier, the heart work like this. These are atria, these are ventricles. The atria, after getting filled from the superior vena cava and inferior vena cava, it contracts to pump blood in the ventricle. This time the AV valves are open. When the ventricle is filled and the atrial contraction is complete, the AV bundles will close and ventricular contraction will start. This is systole. This is systole, and the blood will be pumped from the right ventricle to the lung and from the left ventricle to the peripheral circulation. Okay? So the atrial contraction contributes to about 25% of the pumping action of the heart. That's why if something goes wrong in the atrium, the cardiac output will go down. Okay? This can lead to decreased cardiac output and ultimately decreased tissue perfusion. I beg your pardon. Next slide, please. What do we see in atrial dysrhythmias? First of all, the P waves. Okay, the P wave atrial dysrhythmia is a preterm. There is P wave, but it is not normal P wave. Okay, because there is a different location. So if it's located at the level of the SA node, the PR interval will remain 0.2. If it is in the mid-atria, lower than the SA node, then the PR interval will shorten and the P wave will get smaller. Is this clear? Okay. If it is multiple, if there are multiple loci, okay, then you will have a different P wave and different PR intervals. Okay. The QRS complex will appear narrow with most atrial dysrhythmias. Next slide, please. What types of atrial dysrhythmias or arrhythmias? By the way, dysrhythmia is a better term than arrhythmia, okay? Because A means no. So arrhythmia means stand still, means the patient is dead. But dysrhythmia means disturbance of rhythm, okay? But anyway, a common name is atrial arrhythmia, okay? It could be sinus bradycardia, sinus arrhythmia, sinus tachycardia. We will look at this table and we will go to them one by one. Next slide, please. Yeah, this is sinus bradycardia. You can see that there is always a P wave followed by QRS, and then there is a T wave. So this is a normal cardiac cycle. This is a normal cardiac cycle. This is a normal cardiac cycle. But the heart rate is slow. So this is sinus bradycardia. This occurs with hypothyroidism. It occurs with athletes, those who do exercise, and actually it is associated with exercise. I mean, in athlete people, then it is better because a slow heart rate is much better for the health of the heart than a rapid heart rate. Next slide, please. This is sinus tachycardia. Again, here you can see this is ECG from a 29-year-old female with sinus tachycardia. The heart rate is 125 beats per minute. But again, the cardiac cycle is normal. There is P wave, QRS, T, and the heart is regular, dead regular. Okay? This occurs with anemia, it occurs with pyrotoxicosis, it occurs with fear and excitement. Okay? It occurs with exercise. Yes. Next slide, please. A premature atrial contraction. Yeah. A premature beat could be atrial, could be ventricular. Okay? But these are atrial. How can we differentiate atrial from ventricular? The atrial premature beat are normal in configuration. Okay? You see, there is P wave, there is PR interval, there is QRS followed by T. So it's quite normal. Okay? But it comes prematurely. It comes prematurely. You see, in here, this is a normal heart rate. But this one is a premature atrial. A premature atrial is usually followed by a long compensatory pause. So the beat after it will be delayed. But one factor which is very important, that the R of this R, okay, forget about the ectopic, to the other normal R, which is this R, which is normal, is exactly equal to this R, from this R to this one. Okay? Is this clear? I will say it again. This distance is equal to this distance. But this one is short, this one is long, but if you take 3 beats, then it's the same. Next slide, please.
يعني عفوا دكتور، تقصد يعني كل 3 بيتس، يعني هسه اذا نرجع عليها هنا، يعني نقصد هذا وهذا، يعني 3 مختلفه بعدين، يعني كل 3 متساوي ل3 اللي وراها، هذا قصدك؟
محمد صوتك مو واضح، ما دا اسمع زين. شنو السؤال؟
دكتور يعني اقصد المسافه، يعني كل 3 بيتس يعني مساوي لل 3 بيتس اللي وراها.
محمد اسمح لي، اكو بالساوند، يعني صدى دا يجي. بس انا يعني اعرف راح اعيد كلامي مره ثانيه. اوكي؟ اوكي. نعم. This is slide shows atrial ectopics, and how do we differentiate atrial ectopics from ventricular ectopics? Atrial ectopics has a normal configuration, a normal QRS, a normal P wave, a normal PR, a normal T wave, as you see here. For example, this one. Okay, you can see that it's quite normal. Okay, this one is quite normal as well. Okay, the ventricular ectopic is different. And there is another differentiating point. An atrial premature beat will come early. Okay, if you take this beat to this, these are 3, these are normal. Okay, but in here we have a premature one. Okay, this premature comes earlier, before time. It should have came here, but it came here. Okay, but it is followed by compensatory pause by a longer time for the third beat. Okay, so the RR will remain the same. You see, this R, this R to this R is exactly equal to this R and this one. I will say it again. Yes, from here, I don't know, from here to here, this R to this R equal to the distance, this R to this R. Is this clear?
تمام دكتور واضح.
Okay. Go to next slide, please. This is atrial tachycardia. Okay, you can see the red arrows here point to the P waves, and the P waves are of different shape, and the PR interval different length as well. Okay, so probably this is a multifocal atrial tachycardia. You can see that the heart rate is very rapid, as well. Okay, next slide, please. Yeah. What are the causes of atrial tachycardia? Okay, here you have a list. Hypoxia, pulmonary disease, ischemic heart disease, stimulants like cocaine, caffeine, chocolate, and ephedra. Alcohol is a very common cause, okay, and metabolic disturbances, and sometimes as a result of digoxin toxicity. Okay, this is the list of causes of atrial tachycardia. Next slide, please. This is multifocal atrial tachycardia. Again, you can see that the P wave are different from each other. Okay, indicating, look to these arrows in here. Okay, this is very small P wave. This is a P wave which is a little bit bigger. Yeah, and sometimes the P wave even inverted. Okay, this will tell you that the ectopics in the atria are at different sites. Next slide, please. How do we treat atrial tachycardia? Beta blockers are probably the drugs of choice. Okay, magnesium and potassium. You should, in these cases, you should check the potassium because hypokalemia can cause it. And if this is the case, correct the potassium. If the magnesium is normal and you give magnesium, then the arrhythmia will respond. Okay, but please don't do this with the potassium because the potassium is very dangerous if a patient is overdosed with it. Okay, the second drug are the calcium channel blockers like the rapamyl and diltiazem. Okay, beta blockers are probably superior to them, but if the patient has a contraindication to a beta blocker like COPD or bronchial asthma, then the choice will be for a calcium channel blocker. The rapamyl is the rapamyl can be given intravenous. Quick. prolonged atrial flutter can ultimately increase demand, and it can cause atrial thrombosis, but much less common than atrial fibrillation. Atrial fibrillation as a cause of thrombosis is much more common than atrial flutter. By the way, atrial flutter sometimes change into atrial fibrillation. It starts as flutter, then it shifts to atrial fibrillation. Next slide, please. What not always fatigue, lightheadedness, shortness of breath, and less commonly angina and hypotension is common, but only at the beginning of the atrial fibrillation, and once the patient is on the floor, he regains consciousness. Next slide, please. This is the ECG of a patient with atrial flutter. Okay, you can see these are atrial contractions. Okay, and the QRS is the ventricular contraction. So you can see this one is 5-1, 5 atrial beats, 1 ventricular contraction. Then this one is 4 atrial contractions, 1 ventricular contraction. So this is called atrial flutter 5-1. This is called atrial flutter 4-1. Next slide, please. Treatment. Control ventricular rate. Ventricular rate is high. Reversion to normal sinus rhythm and maintenance of normal sinus rhythm and prevention of systolic embolization. I will discuss this, the prevention of systemic embolization with atrial fibrillation, and it's the same principle. Next slide, please. Control of ventricular rate, intravenous calcium channel blocker, intravenously, verapamil, in my experience, is very effective. It is given intravenously, but very slowly under monitor. You keep your eye on the monitor, give the drug slowly and see what happens. It comes in vials of 5 milligram. But if you get a response at 3 milligram, don't push the rest of it. If you get a satisfactory response, just stop. Okay, and always do this yourself. Don't let the nurse give intravenous verapamil. Okay, digoxin sometimes is given. Amiodarone is a very good drug. Amiodarone is very manageable. What do I mean by manageable? You can put it, amiodarone can be given orally or intravenously by infusion. By infusion, you dilute it with 5% dextrose, 200 ml, and you run it over time. Okay, so what I usually do, I put 300 milligrams and 200 ml. If the rate is, I will decrease it. Okay, and if it was fast, but now it's satisfactory, I will reduce the rate. So it is a very manageable drug, but again, amiodarone by infusion should always be given under monitoring. Next slide, please. Reversion to normal sinus rhythm, and this can be done by many ways. It can be done by cardioversion, okay, and atrial flutter usually easier to respond than atrial fibrillation. Atrial fibrillation is difficult, and supraventricular tachycardia is even easier. Okay, and it can be done by drugs. And when a drug, again, is amiodarone. So when you take amiodarone, you don't only control the rate but you may convert the rhythm as well back to normal. Next slide, please. Yes, this is chemical cardioversion. I have already said this, but you can look to the slide. Yes. Next slide, please. Anticoagulation. Anticoagulants are indicated in atrial fibrillation, in particular, in cases, take it from me, the danger of embolization with atrial fibrillation is high. And every now and then, you lose a patient or a relative or a friend because he was not anticoagulated. And what I sometimes I find that doctors don't put patients on anticoagulants, which is what I will discuss with them, inshallah. Next slide, please. Ablation, yes, this can be done in atrial fibrillation, and it can be done with atrial flutter sometimes, and even sometimes with atrial tachycardia. Okay, a high frequency ablation. Next slide, please. Yeah, atrial fibrillation. Atrial fibrillation is a very important topic. Very important topic. Okay, in your exam and in your atrial fibrillation, a short case you have to diagnose atrial fibrillation by feeling the pulse of the patient and finding that the pulse is irregular. Okay, and you remember probably one day when you, Muhammad, presented a case, I told you always should differentiate between regular tachycardia and irregular tachycardia. And irregular tachycardia could be regularly irregular or irregularly irregular. Okay? And atrial fibrillation is irregularly irregular. If you can't hear the tap, we will tap on. This is regular tachycardia. This is regular with some irregularity, and this is the one which is coming now is totally irregular as in atrial fibrillation. Listen carefully. Something like this, okay? So what you see, can you see my pointer? Muhammad, do you see the pointer?
بدي اشوف البوينتر مالتي انا اريد اسوي.
ما تشوفوا؟ Okay. Atrial fibrillation is one of the most common atrial dysrhythmia. On the ECG, it is, as I said, clinically irregular heart, and an irregular heart, commonly atrial fibrillation, less commonly wandering atrial pacemaker. I will say it again. Irregular heart, commonly atrial fibrillation, less common wandering atrial pacemaker, and I have discussed already these two. Okay. There is absence of the P wave on the ECG. This is an important criteria. The P wave, instead of the P wave, you will get fibrillatory waves, and I'll show you an ECG of that. Okay, so the P wave is replaced by F waves. Ventricular response is totally irregular. That's why it is termed irregularity. Next slide, please. Yeah, this is the ECG. This is an ECG of atrial fibrillation. You can see that the heart is totally irregular. Yes, compare the R wave. They are totally irregular. And sometimes if it's very rapid, it's difficult to tell whether irregular or you have to measure them. Okay? Yes. And there is absence of the P wave. There is between the R wave. Okay? Yeah. When atrial fibrillation is acute, then the fibrillating waves are very clear. When atrial fibrillation is chronic, then the fibrillation waves will go down. It will be smaller in amplitude. Next slide, please. Yeah, this is the treatment of atrial fibrillation. Okay. You can use beta blockers. Okay. Any one of the beta blocker. You can use a calcium channel blocker like verapamil. Then oral anticoagulation should be given, but not only oral, injectable as well, and I will come to this. And then you have to control the green, showing that you have to control the rate, okay? And give the red antidysrhythmic drugs or cardioversion or catheter ablation or AF surgery. And I will tell you now, suppose that we are sitting in casualty and we receive a patient with atrial fibrillation. Go to the ECG slide, please, the previous slide. Yes. Okay. Suppose that this is a 68-year-old man, comes to casualty. He's probably hypertensive on antihypertensive treatment, and take it from me with this atrial fibrillation, the patient will be dyspneic, gasping for air. Why? Because the ventricular filling time is diminished and the atrial contraction is not effective. Okay, so the cardiac output will go down. How do we manage this patient? And we will discuss the treatment of atrial fibrillation. First of all, put the patient to bed, check the pulse, check the blood pressure, put him on oxygen. Okay, and then you may give verapamil or beta blocker, but I usually like amiodarone. I like amiodarone very much. So what I usually do, first of all, I will put the patient on low molecular weight heparin. I will inject the patient subcutaneously one of the low molecular weight heparin like glixan. Okay? Why I should give injectable anticoagulant? Because if this atrial fibrillation converts back to sinus rhythm, then during the time of fibrillation, a thrombus could have formed inside the atria. And once the heart resumes a normal cardiac cycle, the atria will start contracting and the thrombus will be dislodged and pumped in the ventricle, and from the ventricle it will go to the cerebral artery, causing a stroke, a CVA, which is a very big problem. Sometimes it go to one arm and block the artery. It can't go anywhere to the mesentery and the abdomen, but commonly it go to the higher up to the head. And I will put the patient on amiodarone. I will put 300 milligram of amiodarone, which is 2 ampoules. Each ampoule has 150 milligram. In 5% dextrose, it's not given in normal saline. should be 5% dextrose, and run this over, say, 4 hours, or 3 hours, or 2 hours, or 1 hour if the heart is very rapid. Okay? But as I said, under monitor. And once the heart rate goes down, I reduce the rate of the amiodarone, rate of the infusion. Okay, there is a cannula and IV line is going. Okay, and in this way, I will admit the patient. Of course, I will treat if the patient is hypertensive, I will give him antihypertensive, anti-failure, if he's in failure. And as I said earlier, if there is congestion in the lung, we may give furosemide intravenously, 20 or 40 milligram to relieve congestion, pulmonary edema. And usually these patients improve quickly if treated appropriately. Okay, and then I will wait. Most recent atrial fibrillation, probably over 80%, will finish spontaneously. Okay, and that's it. If after 3 days or 4 days, or in this slide they said up to 7 days, but I don't agree. I usually wait for only 3 days. If after 3 days the patient remains in atrial fibrillation, then most probably this, I will say it again, if the atrial fibrillation is acute, then there is about 80% chance that it will convert in the first few days. But if it didn't convert after a few days, then most probably that's a permanent atrial fibrillation. Okay? In this case, if the patient's heart is decompensated, we better cardiovert. Cardiovert by synchronized cardioversion. Okay? And atrial fibrillation is usually a resistant dysrhythmia. So we start with 50 joule, 100, 150, 200, until the patient goes back to sinus rhythm. Okay? Why I choose the amiodarone? I choose the amiodarone infusion for 2 reasons. Number one, it is easy to manage. Okay, if it remains high, I can increase the perfusion. Number one. Number two, the amiodarone itself may convert to heart back to normal sinus rhythm. Okay, but I will say it again. Don't forget the anticoagulants. Okay. If there is no underlying cause, but if there is underlying cause like microstenosis or thyrotoxicosis or cardiomyopathy, then don't try cardioversion, because it will go again into atrial fibrillation. In this case, we just control the rate, and we control the rate with many drugs are available. Digoxin is a good drug to control the rate. Beta blockers are reasonable, good rates. And amiodarone itself, tablet orally, again can be used to control the rate. But digoxin is superior to amiodarone orally. But intravenously, amiodarone is much superior to digoxin. Next slide, please. Yes, we have discussed this slide. Next one. This is a wandering atrial pacemaker. What do we mean by wandering? Wandering means متنقل. If you say this person is wandering about, means he doesn't have a target. He's just going from here to there. Okay? So in this condition, there are more than pacemaker in the atria, and each one of these foci will discharge at a time. Okay? So as they are at different levels in the atria, the P wave will be different, and the PR interval will be shorter or longer. Okay, that's why the heart will be totally irregular, okay, but there is always a P wave. There is always a P wave before each QRS. Okay, you can see here the P waves. This is wandering atrial pacemaker. As I said, it is the second commonest cause of irregularity in the heart. Next slide, please. Actually, this wandering pacemaker, I should have put it at the very end, but it doesn't really matter. Now we go back to atrial fib, because atrial fib is a very important condition. It's the most common cardiac dysrhythmia. The prevalence increases with age. You can read the rest of the slide. Compared to about 1% people younger than 60 years, spontaneous discharge by ectopic pacemaker cells in large pulmonary veins. And this is one way of treatment. If you ablate by radio.
شباب الصوت يمكم واضح؟
لا ما في صوت.
دكتور بس عفوا ممكن تعيده لأن شوي صوتك كان ما واضح.
شنو اللي أعيده؟
من الجوين يعني بين الليفت pulmonary veins والليفت من وصلت هاي النقطة.
أنا ما دا أسمع صوتك زين لكن أوكي I will discuss this slide again. I said atrial fibrillation is one of the commonest dysrhythmias in the heart, and it's important as well. In atrial fibrillation, there is a GIF, Muhammad, I have sent the picture, and GIF, have you seen it? Yes, very good. You can see this one, this is how the heart works normally, okay? The upper part are the atria get filled with blood from the superior vena cava and inferior vena cava. This is the right atrium, and then it pushes the blood to the right ventricle, and the left atrium push the blood into the left ventricle, and the left ventricle to the circulation. Next one, please. This is normal. Yes, this is the haphazard contraction in atrial fibrillation. Do you see the atria? The atria are actually not pumping the blood at the time when the AV bundles are open, okay? And there is a turbulence in the atria, and there is a stasis rather than turbulence in the atria, and the stasis will form a thrombi, and these thrombi, if they go to the atria, if they go to the ventricles, if they go to the left ventricle, ultimately they will go to the peripheral circulation. In the right ventricle, it may go to the lung, causing pulmonary embolism. Let's go back to our slide, please. Okay, next slide, please. Causes. This is a list of causes of atrial fibrillation: ischemic heart disease, valvular heart disease, particularly mitral stenosis, hypertension, congestive cardiac failure, left ventricular failure, COPD, thyrotoxicosis, And the commonest of all is idiopathic. No cause is found. Idiopathic is the most common of all. Okay, and the congenital heart disease mentioned here, but again, is common, particularly atrial septal defect. The commonest of congenital heart disease is atrial septal defect to cause AF. Next.
دكتور عفوا بالمايترال ستينوسس.
Pardon?
دكتور تسمعني؟
ايه ده اسمعك لكن صوتك مو كلش واضح محمد. شنو؟
دكتور بالمايترال ستينوسس عادة يعني يكون الاي اف اتريال فيبريليشن عادة ورا ما يصير ليفت اتريال انلارجمنت يعني لو من البداية.
With enlargement or without enlargement, not necessarily. But if the atrium is enlarged, because the ventricle will not enlarge in mitral stenosis, but the left atrium will enlarge. If the left atrium enlarge, then the chance of fibrillation is higher, and the chance of embolization is much higher, because the stasis will be more. But can it occur with mitral stenosis early while the left atrium is still normal in size? The answer is yes.
Okay, شكرا دكتور.
I have the impression, Muhammad, that you were told by somebody else that unless the atrium is big, atrial fibrillation will not occur. Am I right?
نعم دكتور يعني.
لا, it can occur even if the left atrium is normal. And as I said, but when the left atrium enlarges, then the chance of thromboembolism is much higher. And the need for anticoagulation again is definite. Next slide, please. What are the symptoms of AF? Often AF is asymptomatic. A patient comes for another reason and you feel the pulse, you listen to the heart and it's irregularly irregular. But sometimes the patient complains of palpitation, particularly at the onset, at the very beginning of AF. Okay, if the patient is intelligent, then he may tells you that the heart is irregular. His heart is irregularly beating. A patient may present with heart failure because a patient with compensated heart failure, if he develops AF, he will go into a decompensated state. Okay, syncope is common at the onset of AF, but not later. Very common at the onset. And as I said earlier, if the patient is standing, he may fall to the ground, but once he is on the ground, he will regain consciousness. Lethargy, shortness of breath, acute coronary syndrome and angina, all these are possible with rapid AF because the oxygen demand of the heart will increase. Next slide, please. What are the complications of atrial fibrillation? Systemic embolization on the top, and this is prevented by about 70% or 67% by anticoagulating the patient. Okay, heart failure. Why the patient will go into heart failure? Because he will lose the 25% of the pumping action of the heart, which is usually done by the atria. Systemic emboli are mainly the cerebrum, are due to irregular heart. Yes. Next slide, please. Classification of AF, it could be paroxysmal. Paroxysmal means on and off. And by the way, this is even worse than the permanent atrial fibrillation from the point of view of embolization. Because when the atria is fibrillating, an embolus will form. And when the heart resumes sinus rhythm, atrial contraction will come back and it will dislodge a thrombus. Okay? So if atrial fibrillation is paroxysmal, then the patient should be anticoagulated. Mind you, sometimes atrial fibrillation occurs once in a heart, in a lifetime. If atrial fibrillation occurs once in a lifetime, then there is no need for anticoagulants. Persistent, if after 7 days the atrial fibrillation is still, the heart is still fibrillating, this is called persistent. And permanent, the one which is always fibrillating. Next slide, please. Yeah. This is the work you have to do. Of course, you have to, first of all, take history, whether this is the first attack or not, examine the patient, pulse, blood pressure, oxygen saturation, respiratory rate, etc. Then check the blood sugar, a complete blood picture, ECG, echocardiogram, again is important. Is not documented by the ECG, but the suspicion is there. You may do Holter. You know what Holter? Holter is a little thing attached to the patient, and it can record ECG over 24 hours or 48 hours or sometimes 2 weeks. Okay, and then you put it in computer, and the computer will pick up the abnormalities and show it to you. Next slide, please. Treatment of atrial fibrillation. Okay. If hemodynamically the patient is stable, this is the treatment of AF when the patient is hemodynamically stable. Okay. A slow heart to a normal using a rate control. And the rate control, as we said earlier, I have discussed this, a beta blocker, a calcium channel blocker, or digoxin. Okay? Use adequate anticoagulation therapy to prevent emboli. What I do, when a patient is admitted, as I said, immediately I will start low molecular weight heparin, like glixan subcutaneous. Okay. Next morning, if the patient is still fibrillated, I will put him on warfarin. And here is the question: why don't you put the patient on warfarin from the beginning? Because warfarin is low acting. The half-life of warfarin is 3 to 5 days. You better take it clinically as 5 days. Okay. So next morning, I will give 5 milligram. And again, low molecular weight heparin. Then 5 milligram. And again, low molecular weight heparin injection. 5 milligram, 5 milligram, 5 milligram. And all this period is covered by, I said, the half-life is 5 days. So on day number 1, you have the effect of the first dose. On day number 2, you have the pharmacological effect of dose number 1 and number 2. On the third day, 3 doses, etc. It's accumulative. Okay. On day number 6, the night before, I will stop the low molecular weight heparin, and on day number 6, I will take the PT and the INR. Our goal is to keep the INR between 2 and 3. If I find, suppose that I find that the INR is 5, this is high, what I will usually do, I will stop the warfarin probably for 2 days, because each day will reduce the INR by 20%. Why 20%? Because we said that the half-life is 5 days. Okay? And then we restart warfarin, but at a lower dose. If the INR is still low on day number 6, I reassume the normal molecular weight heparin and I increase the dose of warfarin. If I find that the warfarin, the INR is 9 or higher, we consider this to be very high. The 5 is not very high, but the 9 is very high. I usually, if there is no bleeding, I give intravenous vitamin K because warfarin works as anti-vitamin K. Okay? And take it from me. If you give intravenous vitamin K and check the INR after 3 hours, you will find it within therapeutic range. Okay? This is not written, but this is just experience. Okay? If there is bleeding as well, you better give a fresh frozen plasma because fresh frozen plasma has the anticoagulant factors already in them. While if you give vitamin K, the liver from vitamin K will synthesize the anticoagulation factors. So if you are in hurry, there is a bleeding, fresh frozen plasma. If there is no bleeding, but the INR is high, vitamin K. If no bleeding and the INR is just a little high, but not very high, you stop for a day or two, and then you resume warfarin with a lower dose. And you keep seeing the patient frequently, once every week to start with, then every 2 weeks, then probably once a month. And if the patient remains fibrillating, he has to remain on anticoagulants. Yes, okay. If the patient is young and there is no underlying heart disease like no mitral stenosis, no mitral regurgitation, then I will cardiovert to sinus rhythm. I will sedate the patient because cardioversion is frightening. Okay, next slide, please. This is the Chad's score. Okay, I'm sure you came across this. Okay, and it will tell you when to anticoagulate and when to not anticoagulate. And they give sometimes aspirin as antiplatelet. In my experience, aspirin is not enough. I tend to anticoagulate more than not to anticoagulate. Do you got my point? But you have to have an idea about the child's score. Next slide, please. Yeah. Acutely unwell, I have discussed the treatment. Acutely unwell, anticoagulate, control with amiodarone, but if the patient is very unwell, then immediate cardioversion. Okay, and use a high G because atrial fibrillation is resistant. Okay, this cannot be discussed. You have to see somebody doing this in front of you. Next slide, please.
هاي كملت.
Okay, thank you very much. Inshallah, some other time we will do the ventricular dysrhythmias. Any questions?
دكتور بس الاتريال فيبريليشن يعني احنا بصورة عامة نقدر نعتمد على الديوريشن على مود انه اني يعني انتي اريثميك دراج، لانه يعني احنا يعني اللي درسناه انه بعد ال 48 اور ما راح انطي انتي اريثميك دراج، راح ابلش انتي كواجولانت واجل الانتي اريثميك دراج. فاني اقدر يعني اعتمد على الديوريشن؟
اي طبعا، يعني الاتريال fibrillation the patient may tells you that he has been fibrillating for a long time. This is number one. Okay, but with acute fibrillation, because acute fibrillation usually starts very rapid, then the patient will immediately go to the hospital. Okay, but if the patient tells you that I have been noticing that my pulse is irregular and I'm having palpitation for 2 days, yes, accept this from him and take it that the atrial fibrillation is 2 days old.
زين دكتور، يعني الباثوفيسيولوجي مالت الاتريال فيبريليشن هو enhance automaticity.
شلون الصوت مو كثير واضح.
دكتور، الباثوفيسيولوجي مال الاتريال فيبريليشن يعني انه هو enhance automaticity of the heart، يعني كل البوينت مالت الالكتريسيتي بالهارت راح تتحفز.
Yes.
فاني يعني
as I said earlier, do you remember the slide of the anatomy, the first slide? The SI node is the what do we call it? The pacemaker of the heart. By the way, yes, if the SI node have the highest rate, which is 70 to 80 normally, the AV node have a lower rate, about 60. The bundle of His even lower, about 40, and the Purkinje fibers lower down, about 30. Okay? So in atrial fibrillation, there are multiple foci discharging quickly all over the atria.
ايه دكتور، بس اكو نقطة انا ما افتهمتها، يعني احنا اذا استعمل يعني ابليجن، يعني هنا أنا راح يعني كم نقطة احتاج انه اسوي ابليجن، يعني حيأذي الهارت.
الابليجن الابليجن وين تجين؟ usually this point around the root of the pulmonary artery.
الترايكاسبيد.
Okay? Yes. Around the pulmonary artery and you ablate there. شنو يعني وضحي لي السؤال أكثر.
دكتور، يعني أنا قصدي إنه يعني حسب الباثوفيسيولوجي إنه إذا هو ري انتري سايكل السبب مالته أقدر أسوي أبليجن، لأن هي نقطة واحدة أسوي لها. بس إذا يعني الأوتوماسيتي مال أغلب الهارت صايرة، فهنا أنا راح أذي الهارت من أسوي أبليجن.
الأبليجن should be done by expert. Not all patients are. Suppose that the patient has thyrotoxicosis. You don't do ablation. You treat the thyrotoxicosis. Okay? And if the patient, after getting the patient to a euthyroid state, if he remains fibrillating, you cardiovert. Here, there is no indication for ablation. If the patient has mitral stenosis or any deformity in the heart, just control the rate. You will never achieve a sinus rhythm. And even if you achieve sinus rhythm, it will be for a very short time and the patient will start fibrillating again. But ablation is indicated in the idiopathic type. And particularly if the patient is reasonably in good health. And of course, it should be done by experts.
تمام، شكرا دكتور. شكرا.
Any other question? كان مفهوم الموضوع؟
تمام دكتور، عاشت ايدك.
منو بارك الله بك؟ منو ويانا؟
نعم دكتور.
البنت اللي سألت شو اسمها؟
حنين.
نعم.
حنين. Can you tell me how do you anticoagulate a patient?
Yes, doctor. According to the atrial fibrillation, we will start with low molecular weight heparin the first day. Then in the second day, I put in warfarin because it need 5 days to work. But according to the study I had in my session, not in acute atrial fibrillation, just in the chronic I should start. After give يعني دكتور إنه أنا الأنتي أريثميك ما راح أنطيها بحالة الكرونيك AF، يعني لأنه إذا أنطي أنتي أريثميك إذا هو بعد 48 ساعة راح أسوي شاورنج للثرومبوس مالته، فيصير ريسكي.
لا حنين، أنا قلت from the beginning لأنه حتى يعني أنت ما تعرفين شنو اللي راح يصير. But there is a danger with conversion to sinus rhythm, an embolus will dislodge. So anticoagulation start from the very beginning as injectable, which is low molecular weight heparin, followed by warfarin.
Yes, دكتور. تمام.
يلا بارك الله بيكم.
شكرا دكتور.